I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke. So this is the normal anatomy. You see, to complete the circle of Willis, this is the internal carotid artery, and here this is the basilar, and from the basilar you've got two posterior cerebral arteries on both sides. So there's always a communication between the internal carotid artery and the same side posterior cerebral artery, and this communication is called a posterior communicating artery or PCOM. Now, this PCOM is a normal connection between the posterior cerebral and the internal carotid artery. But if you look on the left side of the basilar artery, the posterior cerebral artery here is hypoplastic. This P1 segment is hypoplastic. And in actual fact, this PCOM, this PCA is coming from the internal carotid artery, and it's a much larger dominant PCOM if you compare it on the right side. So here this is called a fetal PCA because this posterior communicating artery is the one which is actually supplying this PCA from the internal carotid artery. So this PCA is not actually being supplied from the basilar. This is a very hypoplastic connection, and this is called a fetal PCA when you have a dominant PCOM from the ICA actually forming the complete PCA. This connection could be hypoplastic, or there could be no communication with the basilar at all, and the artery may come straight just from the ICA with no connection with basilar here. Now with this background, if you look at this patient has a blocked MCA on the left, and if you look on the lateral view, again this complete territory of the MCA is empty, but you can see an artery going down here in the same direction as the inferior branch of the middle cerebral artery. So is this MCA or is this something else? So if I show you this on the still image, if you look at the lateral view, internal carotid, ACA, empty MCA territory I've written here, and if you see, that's the ophthalmic artery, and right opposite to that, this is the area from where the PCOM arises, and then this is the fetal PCA. So posterior cerebral artery is actually coming from internal carotid artery. In this case, it's a fetal PCA that's coming here, and this is actually the middle cerebral artery territory that is empty. And the way to recognize it also is that if you look on the epicranial view, that's the anterior cerebral artery going up, but there's another artery going up right parallel to it, which is going vertically up, because in routine, there should be an MCA going up like this over here, which is missing. But there's another thing going parallel to the ACA. When you have another thing going parallel to the ACA, that artery is a fetal PCA, which you can then reconfirm in the lateral view. Territory of the MCA is empty here, territory of the MCA is empty here, ACA is already present. So what is this third thing? This is the fetal PCA. Now, in the same patient, you can see our wire going with a loop. MCA occlusion was not very obvious there, but now you can see wire going with a loop. It is going in the right direction. This is the MCA direction. So if you look on the lateral view, the MCA, the wire first goes over here, and then it's going to go in this direction. This is just to show you the direction in which the MCA takes off. So this is a still image just to show that the MCA wire it's going with a loop, so it's going very safely, and it's going on its own. So from here it's going to turn and it's going to go in that direction. And then we've done a solumbra, and we've used a balloon tip guide catheter here, so you can see the balloon is occluding, and we've got a 4x40 solitaire X, and that's a Sophia Plus, and now we're pulling everything out, and now you can see a fully recanalized MCA. And if you see here on the lateral view, you can clearly see that now the MCA territory is all occupied with the MCA, and this is the fetal PCA which is still there. And you can now clearly see in the epicranial view as well that you've got an MCA going here, and these are two vertical arteries going up. One is the ACA, the other is the fetal PCA. In the still image, you can again see that's the ACA, that's fetal PCA, and these are the MCA2 divisions, and MCA branches are there. Now this is another patient who presented with, this is an interesting case, who presented with hemiplegia left, and CTA showed occluded right internal carotid artery after the cervical segment and absent right PCA from the basilar artery. So you can see on the CTA, from the clinical side, we thought this was a right MCA stroke. But when we saw the CT scan, CT angiography, the right ICA was totally occluded after the cervical segment, and then the right PCA was also missing from the basilar artery. So which one is the culprit? Is it the right MCA or is it the right PCA? Because the MCA we could see cross-filling from the opposite side. Anyways, we went ahead with the angiogram for this patient, and here when first we did the vertebral shot look at the posterior circulation, and you can clearly see that the basilar artery is giving off a left posterior cerebral artery, but here the right posterior cerebral is missing. We took the shot of the non-culprit left carotid because the right carotid on the CT we knew it was totally occluded, so we wanted to see how the left carotid is filling up. So the left carotid we saw was giving off collaterals to the ACA and the MCA, but at the same time what we could also appreciate was that on the right side there seems to be a thrombus at the point where the ICA would have come and joined in. So internal carotid terminus probably has a thrombus sitting there. So in the still image you can see now that's the missing right PCA. These are the two vertebral arteries, then the basilar, then the left PCA, and that's where the right PCA should have taken off. And then again left internal carotid, and that's the MCA, and left ACA, and the right ACA has also been cross-filled here, and that's the right ACA A1 segment. Then that's the MCA segments, and that's where the internal carotid artery would have been for the right side, and you can see haziness there. So it looks like a thrombus sitting there. So anyways, now the question was, do we open the right missing PCA or do we go for ICA terminus? So we thought the clinical syndrome was fitting more into the right MCA occlusion, and the other thing was that here I don't see much of a stump there for the right PCA. So if there is no stump, it may be risky to attempt that PCA otherwise. So this is how the culprit side carotid looked. You can see contrast hanging there. It looked more like a pseudo occlusion to me. So I tried adapt. I just went in with a guide and a Sophia and did aspiration in the whole carotid, and this is what I got. So you can see that the carotid had pseudo occlusion. You can see slow flow going into the artery, but I thought it was the terminus that was the main issue because there is slow flow going up. So I did a Solumbra at the terminus level with a 4x40 solitaire X and Sophia Plus, and then this is the final result after removing thrombus. And what I could see was that there is a fetal PCA which is coming up right here in between, because that's the ACA. In the middle we've got another artery going up vertically parallel to the ACA as I explained to you, and then we've got the MCA here. And when I saw on the lateral view, we can again see that that's the fetal PCA going there, and that's the whole MCA territory, and then the ACA. So I'm glad that I did not try to open the right PCA from the basilar side, because if I had tried that, I could have perforated the basilar. There was no communication over there. So here I've labeled it for you for your ease. ICA, that's the ACA going there. In parallel, you've got this in the middle of MCA and ACA. This artery going up is the fetal PCA, and then that's the right MCA. Another case where we had a patient presented with posterior circulation stroke and had a distal basilar tip occlusion. On the lateral view, you can again see that's the basilar tip occlusion. So I went in from the brachial approach. I used a SIM2 catheter, went into the vertebral artery, and then you can see that I'm using a Tromo wire to go up and engage my catheter in. Sorry about that. Anyways, so then I placed a 6 French destination sheath in the vertebral artery, and remember we just place it right near the ostium of the vertebral artery. We don't try to go way up, and we don't upsize from 6 French in the vertebral artery mostly. I've taken a Chikai wire from Asahi and a Rebar microcatheter of the Medtronic, and this is a Sophia Plus from Microvention. And the plan is to do just simple adapt at the distal tip, Distal tips of the basilas are, we know, mostly embolic occlusions. So I've done an adapt, and this is the post-adapt image. We can see a right-sided superior cerebellar artery coming here, but the left superior cerebellar artery is missing, and the two posterior cerebral arteries are missing as well. But I don't see even a hint of posterior cerebral arteries there. So I thought it's better to reconfirm first from the carotid side if there is any fetal PCA, because when we went and looked back on the CTA, we thought there was fetal PCAs there. So we stopped. We didn't have a 5 French Sophia or anything smaller for aspiration from the left superior cerebellar artery. We can see some element of vertebral spasm here. So we went ahead. That's the left internal carotid artery image, and you can clearly see a posterior communicating artery coming up there. On the left, you can see posterior communicating artery going down there. So on the right side, then we again engage the right carotid. We can again see this middle artery going up. That's again right-sided fetal PCA. On the lateral view, you can again see that's the right fetal PCA.